Good afternoon, and thanks for the invitation to speak. I'm an academic GP, so a lot of the work and the findings that I'll present today will be quite clinically applied. And if there are any sort of advanced methodological questions, I'm glad Jianhua is around because he's also part of the research team on this work. So the title has changed slightly from the brief that was sent out, but it's essentially about UTIs or urinary tract infections. And I'm going to talk about two studies that we've done recently around this area of work. And it's really looking at UTIs as a risk factor for bladder cancer. And so what I'll talk about today is the clinical problem as part of the background, and then I'll present two related studies. One case control study, which is the one that was advertised in the session notes. And then I'll also talk a little bit about a cohort study, which we are currently doing and preparing for submission. So this is unpublished data, the second study, but we will talk a little bit about that too. And then I'll finish with a little bit of my own experience in terms of using CPRD for cancer research. So the clinical problem really arises from the symptoms of bladder cancer. And most of you, or many of you, would probably know that blood in the urine or hematuria is a red flag for bladder cancer. And about 2/3 of patients with bladder cancer do have hematuria at some point before they are diagnosed. However, bladder cancer can also present with urgency, urinary urgency, frequency, and burning when someone passes urine. And these are symptoms called irritative symptoms of bladder cancer, but they also overlap with the symptoms of a UTI. So UTIs can in itself also be a presentation or a feature or a consequence of a tumor in the bladder. So it's a little bit complex in terms of the symptoms of UTI and UTIs that are diagnosed during the workup for bladder cancer. Usually when someone only has one UTI, the GPs are very good at identifying, treating, and managing them. But when people have multiple UTIs, it may mean something else. And it may be that they are at risk of something more serious like cancer. And from studies that have been done so far, about 30 to 40% of bladder cancer patients do have UTI, either symptoms or diagnosis in the year before they're diagnosed. So it's fairly common. The second challenge with bladder cancer diagnosis is that there is a sex discrepancy in terms of the incidence of bladder cancer. So it's more common in men or males than females. Whereas for UTIs, it is more common in females than males. So there is a bit of a challenge for a clinician to put the two together and to identify people who actually need further investigations when someone comes in with recurrent UTIs. So the current NICE guidelines that recommend investigations for cancer mostly focus on hematuria, or the alarm symptom, blood in the urine, as the main symptom of for investigations. But it does also have this clause that all people aged 60 and above with recurrent or persistent unexplained UTIs be considered for a non-urgent referral. I think there is a lot of ambiguity in terms of the definitions or the recommendation itself, in that we don't know what recurrent persistent means, and it's hard to quantify or to define unexplained UTIs as well. So this really results in quite a lot of inconsistency in clinical practice, and and from work that I've done previously, I've found that there is huge variations in terms of how patients are managed with persistent and recurrent UTIs. So really, the first study set out to study what recurrence actually means in practice. And the objective was to define and quantify bladder cancer risk in people with recurrent UTIs. We wanted to determine the optimal time interval for defining recurrence. and then quantify the risk of bladder cancer for different UTI frequencies. So the way we did it was to use CPRD, Clinical Practice Research Datalink, which contains anonymized data from routinely collected primary care electronic health records. It covers about 20% of English practices at the moment. It contains coded information on diagnosis, symptoms, prescriptions, tests, referrals, as GPs record them. So it relies on GPs coding them. It's broadly representative of the English population by age, sex, geography, and there is a governance process through which one would have to apply for to study or use their data. The huge benefit, or the great benefit of CPRD, is its availability to other linkages to other data sets. And for this study, we used the 4 in red cancer registry, small area deprivation data, HES secondary care data, and ONS death mortality for the second study that I will talk about in a bit. So the study design of the first paper is a case control study. We looked at patients aged 18 years and over with bladder cancer diagnosed over a 20-year period and at least 1 UTI before diagnosis. And each case was matched to 5 controls on age, sex, and GP practice. So this is the flowchart, which shows how we had our final cohort. So it started off with about 1 to 5 case to matched controls, and we ended up with about 54,000 patients. So the first challenge we had was actually defining a UTI event. And clinically, the genuine or the real way of defining or a genuine UTI is by a positive urine culture. And that's defined as the growth of a single type of bacteria at or above a specific threshold. However, in practice, GPs don't normally do urine cultures, and we don't need to, and that's written in the guidelines for treating UTIs. And we are allowed to treat UTI based on symptoms only. And therefore, not everybody with UTI symptoms have a urine culture. There is the point of care test, the urine dipstick, which can help to provide a guide as to whether it's likely to be an infection. So most GPs would probably do one, but there is variable diagnostic accuracy depending on a population. So age, for example, is a big factor. So what we did in this study was to use a combination of clinical codes relating to UTI event to identify or to come up with a cohort of interest. So we included diagnosis codes of UTIs. We also included symptoms and signs, as well as prescriptions that are used for UTIs. And thankfully, the prescriptions for UTIs are generally fairly specific for UTIs. So they're not commonly used for other infections. And so we are pretty comfortable or confident that they represent episodes where patients might have had UTIs or UTI symptoms. The second challenge we then had was defining recurrent UTIs. But of course, this is also one of the objectives that we're trying to achieve in this first paper, which is what is recurrence in itself. And the time interval was the thing that we didn't know. So the way we did it was we had a bladder cancer case. For every case, we had a timeline going backwards from bladder cancer diagnosis. And we mapped out all the UTI episodes before bladder cancer diagnosis and took the one closest to diagnosis as the index UTI and timed this as time 0. And then we anchored their matched controls on the same timeline with time 0 set at the index UTI and going backwards. We looked over a period of 10 years from index UTI, but there was very little difference in UTI frequencies beyond 5 years. So we then concentrated on just the 5 years from index UTIs. We then specified look-back time windows, and this is our exposure of interest. We didn't know the time windows, and we pre-specified some of them using existing literature. And then we counted the number of episodes within each time window. So patients were classified into mutually exclusive groups based on the interval and frequency closest to the index UTI. So for the analysis, the main analysis was conditional logistic regression, and we looked at the association between recurrent UTIs and bladder cancer. And then we adjusted for social demographic, clinical, and all the covariates together. In terms of baseline characteristics, if this is just a social demographic characteristics, you can see in the cases we had more men than women, and in controls the other way around. They were fairly similar in age and ethnicity breakdown. So this is the main results. Across the bottom x-axis, we've got time windows and frequency within each time window. And on the y-axis, we've got the odds ratio of bladder cancer. And you can see in the 4 models, from unadjusted to fully adjusted, there was a strong effect size seen within the first 6 months for bladder cancer risk, as well as an increasing dose-response relationship between frequency of UTIs and bladder cancer risk. This forest plot really shows you another analysis we did where we separated the event codes by type. As I mentioned earlier, we included 3 groups of UTI events. The first column shows the results that I've just shown earlier. These are all adjusted analyses. And then the second column shows a model where only UTI diagnosis events were included. And then we have prescriptions events in the middle column, symptoms and signs. And then in the last column, we combined diagnosis and prescription events because they were felt to be more indicative of a true UTI episode because symptoms and signs are less specific and could be related to other conditions. And as you can see, there was still a fairly strong relationship or effect size seen within the first 6 months for most categories. And a dose-response relationship was seen for the diagnosis events, prescriptions maybe, and there were only about 10% or just over 10% of codes were symptoms and signs. So there was a bit of a wider confidence interval seen in that group. We then did sensitivity analysis by shortening the window, the time window in the first 12 months. And initially we had 6 monthly windows in the first year, so 0 to 6 and 6 to 12. And here we have 3 monthly windows to just show whether this pattern still held true. And as you can see, we still had a strong effect size seen within the first 6 months, dose-response relationship also observed, and it is much stronger in both these windows compared to longer time windows beyond 6 months. And this just shows a sex stratified analysis for the first 6 months, comparing increasing frequency, and it just shows a stronger dose-response relationship in females compared to male. So what we found in the first study was that multiple UTI presentations in a 6-month interval showed a stronger signal for bladder cancer risk, and that there was a dose-response relationship, which was stronger in females than male patients. So we found that there was a signal for increasing frequency and bladder cancer risk. But then for it to be clinically useful, we really wanted to know how much risk is there and for whom in this population do we need to act on. So in the second paper, what we wanted to do was to examine the incidence and then of bladder cancer in these people with recurrent UTIs, and then identify the subgroups who cross the NICE referral threshold for fast-track referrals, which is currently set at 3% risk. So this is really just for a policy reference so that we could say which groups may need further investigations. So the methods for this study, we had about 4.8 million adults with at least one UTI between 2000 and 2023. We had a follow-up period from the index date of the recurrent UTI to first of bladder cancer death or last GP registration date. And the main analysis was Cox proportional hazard models to examine associations between recurrent UTIs and bladder cancer. adjusting for the same covariates as earlier, but including hematuria this time because it is a very strong risk factor for bladder cancer risk. And then we also looked at cumulative incidence with death treated as a competing event. So the way we define recurrent UTIs this time is slightly different because it's a cohort study. First of all, the episodes were ordered chronologically, and then we found the first 6-month period in which at least two UTIs occurred. So these are the ones in red, for example, where these 2 or 3 episodes occurred within the 6-month period, and we called it the first qualifying cluster. And then we counted the number of UTIs within the first qualifying cluster and grouped patients into cohorts based on how many UTIs they had in this cluster. The index date was set as the date of the UTI episode completing the assigned recurrence category, i.e. the ones in red. So for the first patient example, they had 2, so they would be in cohort 2, and the index date for the recurrent episode would be the second UTI, the one in red. And for the second patient example, it would be the third UTI set as the index date for the recurrent UTI episode. These are the results from the Cox models. Really, it's just to show you the main risk factors or the predictors for bladder cancer risk. So sex was a strong predictor. Hematuria was a strong predictor. There is an increasing dose-response relationship with increasing frequency of UTIs. Age was also a strong predictor, and smoking was another one. So current smoker especially. So these are the cumulative incidence graphs that we drew for patients over the age of 60. So for those age under 60, the incidence was very low, about 1% maximum over 15 years. So really what we did here was we looked at incidence over 15 to 20 years in 10-year age bands above the age of 60. And we found that for men, they were increasing over time. Apologies, these are the female ones. So might have had the wrong figures in there. But essentially the shapes are the same. But if you trust me on the y-axis, it's up to 4. And it does cross 3% at about 10 to 15 years for many groups. And for some above the age of 70, it crosses around the 5-year timeline. So for female patients, which is similar graphs, but essentially the y-axis is halved in the first instance. So the incidence is about half of that for men. And the main thing to notice for females, they don't cross the 3% at any point beyond even 15 years for all the age groups that we examined. This is a heat map of the incidence across age groups, but also stratified by smoking status, hematuria, and sex. And these are the risk factors that we found from the Cox models that were strongly predictive of cancer risk. And the first thing to note is, again, in men compared to women, the top rows for each big row, there are more cells with darker shades. And again, for hematuria, that's a strong risk factor. There's sort of more shaded cells or darker cells compared to the non-hematuria. But if we were to look at the actual groups of patients who are at risk of cancer, we are talking about mostly men who are smokers, who are hematuria, who had hematuria at some point above the age of 60, all of them, but also without hematuria in smokers, they also have a certain level of risk above the age of 70. So that's the cell, the third cell from the first column down. For women, the main thing to note is a lot of them are quite pale, the cells, so the risk is low. However, there is a slight increased risk in the 70 to 79 age group in current smokers who have hematuria. So there are certain pockets of the subgroups of the population who might be at risk of bladder cancer and may need some sort of close monitoring if not referred. So really, from these two studies, we went from, is there a signal, to how big and for whom? And the first case control study really is quite good at providing, so the CPRD was quite good at providing the scale to study a reasonably rare outcome in primary care, which is cancer. It gave a signal, associations, looking at associations in odds, and defined a time window for recurrent UTIs. And then the second study, the cohort study, really looked at people over time, and it gave the absolute risk with competing death treated as an event, a competing event. And it allows us to stratify risk crossing a certain policy relevant threshold. And it's more applied and clinically relevant for what we do normally. So I'll just go on to talk a little bit about the strengths of the CPRD for cancer research. Of course, we talked a bit about the scale and the power. It allows you to study quite a lot of patients, stratifying by subgroups, but also to study an uncommon or rare outcome. It is linked, as I mentioned before, so it gives a lot more breadth and depth sometimes as well to allow you to study. And for cancer, we have a lot of information about the cancer diagnosis itself and more accurate information around diagnosis dates and stage. And we also, for linkage to the death data, of course, we have the course specific data available as well. It does reflect clinical practice because it's how GPs actually code them. It is a strength as well as a limitation, as I'll come to later. It is broadly representative and it has longitudinal data over time. So we do have quite a lot of data in these data sets, and it's efficient and reproducible. So these codes are usually shared. Code lists for different variables are shared mostly, and we have protocols, and people can repeat it if needed. Limitations. So validity of code. So code lists are generally, they require a lot of validation and clinical input to decide whether they are indeed relevant for the information that you need. I mentioned the limitation with the UTI codes earlier, but thankfully, because UTI diagnosis and symptoms can both be associated with bladder cancer, they are actually both relevant for what we're trying to look at. Defining exposure. So there are different ways to define exposure variables, especially for time-dependent concepts like recurrence and persistence. How do you define it is a question in itself. And of course, the paper one was set out to address this issue partly. There may be coding and indication bias. So who gets tested, coded, and referred is not random. So when GPs code patients and code symptoms, diagnosis, there is already a clinical reasoning and decision-making process that's gone on at the back of their heads, and they may only code what they think is important, and there's maybe a lot of missing information in free text data. There is always missing data with big data sets. Smoking, BMI, ethnicity, BMI especially may be an issue, but with linkages to the other data sets, one can be pretty complete with many of the covariates that you might be interested in. Coverage and generalizability may be limited. So, for example, in our study, the first study only went up to 2018 because of the availability of the cancer registry data, which was only up to December 2018 at the time. But we now have a bit more recent data up to 2025, which is great. But this may have issues for studying more contemporary cohorts. There is also limitation in terms of practice coverage. It may not be representative of all practices within each practice. So the practice types may be different that are the ones that are contributing data to CPRD to your practice type. So some take-home messages. So what we can really draw on from these two studies is that we can be fairly confident about the direction and the dose-response relationship seen between recurrent UTIs and bladder cancer risk. Absolute risk cancer risk is driven primarily by age, sex, smoking, and hematuria. And most younger patients and female patients are generally low risk if we're taking the 3% threshold as the threshold of interest. So we do also need to be quite cautious about looking at the exact magnitudes of the hazard ratios, for example, because of the limitations around the coding issues and around defining the exposure variables. There may be residual confounding, as with all these big data studies that we haven't thought about or be able to adjust for. And I mentioned a bit earlier about generalizability to specific practice populations, so that requires a bit more of a applied lens to see whether this may be useful in your practice. So the implications from our study really come, there are three, I think. So the first is our findings really challenge the currently age-based referral recommendations. NICE guidelines treats everybody above the age of 60 with recurrent UTIs the same. But what we've found is that there is a lot of heterogeneity within this group in terms of cancer risk. And so perhaps we could risk stratify them better to improve diagnostic yield and reduce capacity on secondary care investigations by incorporating fairly easily attainable characteristics such as sex, smoking, and hematuria before diagnosis to target referrals and specialist investigations. So this could be something for future research in terms of whether we want to look into developing some sort of risk stratification tool. But of course, this needs also further work in terms of validation and evaluation before one can use it. So lastly, I'd just like to thank the team. So Siku's a data analyst, and then Jianhua and Fiona, and Jim, who's a urologist in Sheffield, who provided a lot of input into the two studies. If you're interested, this is the first paper which is published, and I'd like to thank the funders as well. Thank you.